Good evening, everybody, and warm welcome from ISCRIS. We're going to do excellent course today on video-assisted teaching classes on challenging cataract cases. And today we are blessed with a wonderful faculty, with chairman being Professor Jeevan S. Tetial and Dr. Rishi Mohan being the co-chairman. Dr. Tetial is the president of ISCRIS, chief and professor of ophthalmology in cataract, cornea, and refractive services, RP Center, AIIMS, New Delhi. Dr. Rishi Mohan is a cornea surgeon at MMI Institute, New Delhi. We are joined by our chairman scientific committee, Professor Namrata Sharma. She's the chairperson scientific committee with ISCRIS, as I just said. She's professor of ophthalmology in cornea, cataract, and refractive services at RP Center for Ophthalmic Sciences, AIIMS, New Delhi. Dr. Ramesh Kumar Singh is a prolific phacosurgeon, senior consultant at Prakash Eye Center, Ashiana, Lucknow. He'll also be the co-chairman for this session. Our wonderful speakers, eloquent speakers, Dr. Rajendra Prasad, Senior Consultant and Director, RP Eye Institute, New Delhi, Cornea, Cataract and Refractive Surgery Services. Dr. Meenu Methan is a Senior Consultant from Trivandrum, a very well-known name. Dr. Sel Vasavada carries a legacy and an excellent surgeon and a speaker. He's a Senior Consultant at Raghudeep Eye Institute. Dr. Punendra Bhasin, a prolific phaco cataract surgeon, a wonderful person indeed, founder and director, Ratnajyoti Netral Ophthalmic Institute and Research Center at Gwalior, Madhya Pradesh. We also have with us Dr. Rajesh Joshi, who is Associate Professor at GMC Nagpur, and Dr. Harshul Tak, a well-known phacosurgeon, Director and Chief Surgeon at Rawat Eye and Phacosurgery Center in Jaipur. Among our panelists, we have a galaxy of well-known eminent persons like Dr. Pawan Rao. He is the Professor and Head Department of Ophthalmology, Vijayanagar Institute of Medical Sciences at Karnataka. Dr. Sanjay Mehta, Director Mehta Eye Care, Azad Nagar at Bilaspur, Chhattisgarh. We have Dr. Arun, is the director of Adichere Eye Hospital in Aurangabad. Dr. Pankaj Kataria is the director, Dr. Pankaj Kataria's Eye Clinic in Faridabad. Dr. Charu Goel from Goel Eye Institute in Sitapur. Dr. Deepthi Govila, senior consultant ophthalmologist, Delhi ENT Hospital and Research, Jasola, New Delhi. I am Dr. Rajiv Mukherjee, and with me soon joining would be our secretary, Professor Rajesh Sinha. With the permission of the chair, I think Dr. Rajesh has joined us. I would request Professor Tetial to give us a few pearls of wisdom before we go into this session. So you're muted.
Thank you, Rajiv, for such a nice introduction to a very exciting evening for all of us. And Rajesh also joined now. I think I would really appreciate the type of video-assisted teaching which you're going to do today, and that is based on a cataract. We know that every cataract surgery is a challenging situation for all of us, not only for a surgery, but aiming to give a perfection to our patient. That is what has become a more challenging for all of us. Onto that, all recent technologies make things much more difficult to talk to the patient in terms of outcome-wise. And what about looking into a different gamuts of a challenging situation like posterior cataract, soft, hard, associated problems? These are everything which makes surgery very exciting for surgeons. That I say because every step has to be perfected to make ultimate outcomes satisfactory for surgeon point of view and patient point of view also. And if I see today's list of surgeries, and very experienced people are going to take us through these challenging situations. I'm actually waiting to learn, tips, because every time we listen to one particular talk from one particular presenter or surgeon, we always learn. And I'll be, really fortunate to go through all these presentations today and see what new messages we can give to our listeners today. Thank you, Rajesh, Namrata, and Rajiv, for making this session for today's Friday. We can start now.
Thank you, sir. A very good evening to all of you, and sorry for joining in late. So we begin the scientific session with some wonderful videos, a video bouquet from some of our best top quality surgeons. So we begin with Dr. Rajendra Prasad, who is known to everyone, and he'll be showing videos on posterior polar cataract.
Not to mention known as the Terminator.
You have to unmute yourself.
Yeah. Thank you, Rajesh, and thank you, ISCRIS, for inviting me here in this beautiful session to speak on posterior polar cataract, which is so I'll be showing the management of a complex posterior polar cataract. Now this video actually which I'm going to show has a voiceover in it. Better explanation, I think I'll just put on the voiceover. So
Didn't get that. Could you try again?
Go through each and every point. So you can see my screen now. Is it visible? Yeah. Okay.
Yes, yes.
Yes.
All right.
This is the video of a complex posterior polar cataract with classical onion peel appearance. But what is unusual about this case is also associated with pre-existing segmental posterior capsular defect along the inferior temporal margin of the cataract. So to commence the surgery, here I begin with anterior chamber inflation with viscoelastic, subsequent to completion of the routine corneal incisions. But while inflating the anterior chamber, one has to take extreme care not to overinflate the anterior chamber. Once the anterior chamber is sufficiently pressurized, I proceed to create central circular rexes of 4.5 to 5 millimeter in size. Larger rexes should be avoided, which may hinder optic capture or sulcus fixation of the IL in case we encounter PC disruption. Now, since cortical cleaving hydrodissection with fluid wave passing across the posterior pole is an absolute contraindication, I normally prefer to do a multi-quadrant hydrodissection with a small bolus of fluid injected without allowing the fluid wave to cross the posterior pole to completely separate the cortico-epinuclear complex from the capsular bag. Once the hydrodissection is complete, the endonucleus of the cataract should be completely separated from the cortico-epinuclear cataractus complex for better manipulation during segmentation and emulsification. So here I'm using dispersive visco to completely delineate the endonucleus from the epinuclear shell. Endonucleus in this particular case looks to be little formed with grade 1 or 2 sclerotic changes. And to fracture the nucleus in all these complex posterior polar cataract cases, I would like to avoid more stressful chopping techniques. So here I'm going to undertake divide and conquer nuclear fracture technique to segment the nucleus with slow motion phaco-parameters, which you can see here. And this will put least stress and strain on the defective posterior capsule. Central trench should be deep enough until the central plaque is exposed. And then with the help of blunt chopper and the phaco probe, the nucleus is fractured into two complete heminuclei. The important point which should be noticed here is we are not rotating the nucleus. We are just trying to hold each heminuclei with the phaco probe, bringing it to the center of the pupil, then sub-chopping it and emulsifying. Now this emulsification procedure is done with the slow motion phaco-parameters where the energy is around 30%, AFR is around 25 cc per minute, vacuum 200 millimeter of mercury, and the bottle height should be still around 70 centimeters. Low parameters help to maintain the anterior chamber stability, reduce pressure on the cataractus plaque, so we could prevent pre-extraction posterior capsular disruption. Once the nucleus is completely removed, we can very clearly see a very thick epinuclear shell, which is actually merged with the central plaque of the posterior polar cataract. To remove this epinuclear shell, we bring down the phaco-parameters, energy to 10%, vacuum to 80 millimeter of mercury, and the bottle height to 60 centimeters. And then with the partial segmentation technique, anterior lip of the epinucleus is held with the phaco probe, pulled it towards the center, and then broken it off at least 4 to 5 millimeter away from the central plaque of the cataract, and then aspirated. This is how we can complete the aspiration of the peripheral rim of the epinuclear shell, leaving behind a plate of epinucleus and the cataractus plaque to tamponade the defective posterior capsule. Then after completion of phaco aspiration of peripheral epinuclear shell, From this point, we'll make a start of high dissect, that is bimanual irrigation and aspiration controlled hydrotraction dissection of epinuclear cataract plate from the posterior capsule. So here we bring in the bimanual irrigation and aspiration cannula to complete the cortical aspiration under very low fluidics and very low infusion pressure, keeping the bottle height at 60 centimeters, vacuum around 100 millimeter of mercury, and aspiration flow rate around 20 cc per minute. This will put least stress and strain on the already compromised posterior capsule. The cortex here you can see is almost free within the capsular bag. This is basically because of the initial hydro procedure which was performed in this particular case. We can hold the cortex from the periphery, strip it and bring it to the center and then aspirate without disturbing the central plaque, which is actually tamponating the posterior capsular defect. After completion of the cortical aspiration, what we see now is a epinuclear posterior polar cataractus plate, which is overlying the posterior capsular defect, but also fused with the posterior capsule. Now, detaching this plate from the posterior capsule is going to be the most difficult part of this surgery, because any attempt to detach this plate from the posterior capsule may suddenly disrupt the posterior capsule and also break the vitreous face and lead to vitreous prolapse. To detach this plate from the posterior capsule, what I'm going to do is I'm going to use hydrotraction dissection technique with the help of irrigation and aspiration cannula. Here, you can very clearly see what I'm doing is, with the help of the aspiration cannula, I'm trying to hold the flap of the epinucleus and then pulling it away from the center, which puts a direct traction on the center plaque. So the center plaque is slowly detached from the posterior capsule. While detaching this center plaque from the posterior capsule, we are simultaneously taking care of the pre-existing posterior capsular defect. So you can very clearly see here that when I'm holding the epinuclear plate with the aspiration cannula, I'm putting a traction, but at the same time, I'm aspirating the epinuclear material. And when epinucleus aspiration is complete, I'm finally holding the plaque and lifting it. So what we see now here is a central circular capsular defect, which appears like a posterior capsular excess. And the important part of the surgery is the anterior vitreous face is intact, so there is no vitreous loss. And once the management of posterior capsular defect and the fused cataractus plaque is complete, the subincisional cortex and the remaining epinuclear aspiration is performed. Now, since the PCC is complete, the anterior vitreous face is intact. So we have planned to implant 3-piece monofocal IOL into the bag. This is how we have very successfully completed the surgery. And this is the 7th post-op day picture. IOL is well-centered, stable, vitreous face is intact, posterior segment is normal, and the patient improved to 6/6 vision.
So this completes the management of this complex posterior polar cataract. And these cataracts where we only know that there is a pre-existing capsular defect. So these are the cases we have to manage in a way we are managing a PCR case. So if you have a nucleus, if you have a cortex and epinucleus in the capsular bag, and then you know that the PCR has taken place. So the management should take place in a similar way as we manage the PCR case. So this is what I have done in this particular case, and we could successfully manage this case without any further complication of the posterior segment or further disruption of the posterior capsule. So this was the biggest aim, to save the further disruption of the posterior capsule. Otherwise, we couldn't have been able to place the intraocular lens into the bag. So we put the intraocular lens in the bag, and you have seen the result. Thank you very much.
That was fantastic. Wonderful surgery shown by Dr. Rajendra Prasad. Any comment from any of the panelists?
Actually, Rajesh, if I may come in, I mean,
Yeah,
couple of mantras in these cases. There is a low flow surgery, low bottle height, and never let the chamber shallow. One thing that we have seen many surgeons do is do an oval rhexis when they are approaching a posterior polar cataract for its obvious advantages. Dr. Rajendra Prasad, any comments on these things?
Yeah, actually, because if you know that the nucleus is grade 1 or 2, then you don't need to go for the oval rhexis. You can just make a small rhexis, as I did in this particular case. Rhexis of around 4.5 millimeters is sufficient to remove this kind of cataract, and that would rather give you a much better protection. Like it won't, there won't be too much of the fluctuation in the anterior chamber and stress on the posterior capsule, which is already disrupted. But yes, if you have a grade 4-5 nucleus, then definitely if you do a good oval rhexis, then you need a space for manipulation of these hard nuclei. Then you definitely need a little oval rhexis so that you could manipulate these hard nuclei and take out it.
Nice. Professor Tityal manages so many posterior polar cataracts and so well. We all have learned from him. Sir, would like to have your comment on this.
No, sorry, my internet got disrupted for some time. But I've seen this video earlier also, and Dr. Rajendra Prasad has given all the tips which are normally has to be taken into a posterior polar cataract. And one of the challenging is what he showed is a pre-existing defect in these cases, and how to decrease the chances of nucleus drop, especially if you have a grade 3, grade 4. Sometimes you do have little harder nucleus also in these cases. And classically, what we try to achieve is to save the epinuclear cushion till the last piece emulsified, and then safely engage the epinucleus slowly from the periphery to center, and take out in bulk. But in recent time, we all understand if you can use the dispersive viscoelastic, like a biscotte type of thing, which can plug the opening when you're trying to remove the epinucleus. So that really saves the enlargement. And we know that most posterior polar pre-existing defects normally don't enlarge like the iatrogenic PC defect which we create. As Dr. Rajiv was saying, if you can maintain the anterior chamber pressure throughout, and it doesn't enlarge that much, you can save that, and sometimes you can make the rhexis type of thing in a posterior polar cataract if your elliptical opening is smaller. But most of the times we can save these posterior polar cataract without having to worry about drop nowadays. And rarely you may have to put in the sulcus lenses. Even I have planned multifocal lenses for these cases also. We know that we can manage very simply in these cases. But whatever we talk about, we all know pre-surgery examination is very critical. What Dr. Rajendra Prasad showed. If you do a good slit lamp examination, anti-segment OCT, you can really know the PC status in these cases. And most of the time nucleus is soft, but sometimes you do get a challenge where you can't rotate the nucleus. The chop technique is showed was classical for these cases. So wonderful depiction of chopping of nucleus without rotation.
Thank you, sir. That was indeed wonderful. Pearls of wisdom from a wonderful cataract surgeon. I will request Dr. Pawan if he has any comments on this particular presentation.
No, sir, no comments.
Thank you, Dr. Pawan. Can we move on to the next talk by Dr. Minumathan on supra-hard cataracts? Is this presentation ready?
Yeah, I'm online.
Yeah.
I'll share screen.
Sure. Thank you.
At the onset, let me thank Dr. Rajesh Sinha for this opportunity. It's always nice to have everyone, including Tityal sir, to listen to. So is my slide visible?
Yes.
Yeah. So going on to
slide share.
yeah. So going on to supra-hard cataract. 1 second. This one is on. Okay. Okay. So the first case I would show is a black cataract. So I would definitely stain the anterior capsule in all these cases so that I'll know what the size of the rexus and what is the margin, where is the margin while chopping, because there is always a chance of hitting the rexus margin during chopping when I'm using a sharp tip chopper. That is the first point. The second thing is I would make a slightly larger rexus, which is close to between 5.5 and close to 6 millimeters if required, according to the size of the nucleus. And then comes the chopper. This is a 1.75 millimeter sharp tip chopper. And the phaco needle, I would use a new needle and the tip a little more exposed. And I classically do a chopping technique, but initially I do a central debulking. So after that, I make the first chop, and I don't insist on a complete full chop if the nucleus is very hard and thick. But then this is a little speeded up video, but it is unedited. But so after 1 or 2 chops, if I get one piece free, I take out that. Otherwise, I can continue chopping. So just to mention that all these techniques are just what my preference is. There are so many other equally good techniques also. So after that goes the BSS is being used, and viscoat is initially used, and it may be replaced as time goes by because you need to protect the endothelium. And the power which you need is required for cutting this nucleus well. See, I cannot say one particular power because each person will be using different kind of machines and their efficiency will be different. And so we need to make sure that they cut very well and your chamber is very stable. Here you can notice that during nucleus emulsification, the chamber remains very stable. And the second instrument after chopping can be used to support the loose nucleus pieces. See, when you have divided all into very small pieces, you can see that 1 or 2 pieces may be floating around, which can hit on the endothelium. So use the second instrument efficiently to keep those pieces down within the bag, because the cortex will be very less, and we have to make sure that you don't hit the endothelium, the posterior capsule also. So we move on to the next one. Here it is a harder nucleus, not so hard, but an intumescent lens. So here the point is to get the rexus. So you can see that it is highly intumescent. So here also I stain. And the first thing I use is HPMC. And on top of that, I use sodium hyaluronate to press down the anterior capsule and tighten the anterior chamber. And then I initiate this is done for all my intumescent cataracts now, the same technique. So I initiate with a small cystitome, make it very small, turn it around a little bit, and go ahead with the forceps. I can use a microrexus forceps or a thin Utrata classical forceps, maximum 2.5 to 3 millimeters. After that, I use my coaxial. You can use a bimanual or a Simcoe or whatever aspirating instrument, aspirate in the rexus area. After that, I go under the rexus a little bit, because initially later on when we are extending the size of the rexus, you need to go to the mid periphery. Mid periphery should not also be pushed up with the loose cortex there. So tapping on the sides and rotating the nucleus, I can use a second instrument also, or the same irrigating instrument itself to rotate the nucleus. And while rotating, you can free a lot of cortex, and most of the anterior cortex comes out now. So once this is done, this is just like any other cataract now. So you fill up the anterior chamber. Now I don't use high molecular weight viscoelastic. This is just SPMC. And then I make a nick, which is an oblique nick on the rexus margin, and move it around the rexus which you have already made. And here I can use a microrexus forceps also. People tend to use it through the paracentesis. Fair enough. I'm used to doing it through the main incision. That's also fine. So make it large enough to continue our phaco easily. Most of the nuclei may not be that very hard, and they may be smaller also, but sometimes you'll find very hard nuts inside such kind of intumescent. In very old people and all, nucleus will be definitely hard. This is not such a soft cataract. So the next thing will be the same thing what we saw there, central debulking and chopping with a sharp chopper. And either we can completely chop it into different small pieces and then take out each piece separately, or take out as and when we chop. Moving on to the next stage of hyper-mature Morgagnian kind of cataract. Here you can see that it is milky. It's not very tense, but then it is totally milky. And you don't know what is the size of the nucleus which is inside. So once it comes out, I aspirate the leaking cortex with the same needle itself. The syringe which is connected to that, I retract the plunger and take out most of the cortex which is coming out. Then I use my forceps, fill up the bag with visco and the anterior chamber with viscoelastic. There may be very large calcific spots. If there are very large ones, make sure we don't run into them, because once you encounter a large one, then you may not be able to proceed. Now you can see it is not so small, but it is very loosely rotating inside the bag with the fluid flow. And here it is very difficult to stabilize the nucleus to manage. So here I do something like moving the nucleus to one corner, inflating the bag with the sodium hyaluronate, and injecting the IOL now itself. Just tilt the lens a little bit, and this lens goes into the bag. Now the bag becomes more full, and the nucleus doesn't move, and also the PC is protected, and the phaco happens within the bag itself. Only thing to make sure is that your chopper or your phaco probe should not touch the optic of the IOL, and chopping happens just like routine. I divide it into all small pieces. You can see that the posterior plate is leathery, but not that very leathery. And once that is done, it is emulsified routinely, but then always under viscoat, or there are other Indian companies also which make dispersive viscoelastic, which we need to put liberally and repeatedly to make sure that your endothelium is remaining clear. So, and later on, there is nothing much to aspirate and the case is over. So to end with, this is a relatively younger man. This is a central hard nucleus with calcific spots on the capsule and inside the nucleus. So this one was a flat nucleus, thin nucleus, but very, very hard. And I make a relatively large rhexis, and you see that there is a fibrosis here. I become little lax and just go right into it. But then I was lucky enough that I could pull it back in. Sometimes you may not be able to do that. So I go in with the chopping, and now I realize that there is a big bright red area in the center. And I am little upset about that. So I make another chop, which is not complete. Here I am intentionally not cutting through the center of the posterior plate. I am retaining all the pieces as in one bulk. And I now rotate and see again that the central area is very clear, and there are margins. So now I embed into the nucleus and bring out the whole nucleus into above the rhexis level, just on top of the iris. And then I do a supracapsular phaco. See now again, this area, which is very clear with a margin, calcific margin. So that gives me a feeling that there is an open capsule. So I take out individually pieces, small pieces with viscoat cover, and not separating all these pieces. See, when there is a piece end, if you separate into small pieces, it is very easy to get a nucleus drop, rather than keeping it all connected together and taking out the periphery first. This is a petalloid chopping. And now I see more of PC. So here is the margin which I saw there, and the central area, but there is nothing coming up. I push on it. There is no problem. There is no piece, and then I'm happy. And I rotate back the nucleus, the rest of the nucleus back into the bag. And then I can complete my chopping. I can separate it into smaller pieces and take out. So here, this case also finishes like a routine case, but initially it gave a little scary feeling that the posterior capsule was open. So again, I would stress the use of viscoat or other dispersive viscoelastic which are available that can be replaced while doing the phaco itself, and the lens goes well into the capsular bag. Thank you very much.
Fantastic, Dr. Meenu. Those excellent surgical skills on hard cataracts, and that IOL scaffold technique was an amazing thing to watch. I would look forward to a few tips from you on chattering. I saw you do vertical chopping. Sometimes you have this kind of a nucleus torsion when you're trying to do a vertical chop. And sometimes you also have the chattering in front of your phaco tip when you're dealing with hard cataracts. How do you handle this two situations?
So torque, thank you, good question. The torque which happens is mostly because your hold is not good. So when you're using nozzle, I nowadays tend to stop nozzle and do with longitudinal, so that I have bursts of energy which go into the nucleus and hold well. Because when you have this Centurion and your balance tip and all those, they cut so efficiently, they cut that when you try to embed, it cuts off whatever is there in the front, and it doesn't give you a good hold. So when you don't have good purchase and vacuum built up and hold on the nucleus, then you tend to the nucleus tend to slip, and you see the torque when you're trying to chop. The second thing is chattering which happens at the tip. When sometimes see the tip getting clogged is one point which we need to remember when we are using smaller tips. So many people tend to use very broad tipped phaco needles so that the clogging doesn't happen. And the nozzle, when it tends to have this harder nucleus, it tends to get clogged. And so I use the IP always on when the longitudinal also happens in between, when it tends to clog the tip. And then you mostly get away with without clogging, but always make sure with the second instrument also that you don't occlude too much. This is with the torsional. But if it is longitudinal, it's good to always block the tip and get the vacuum on and then do phaco, and adequate phaco power so that you cut through very well. And make sure you don't make very small too many bits, so that some of them will tend to run around with the irrigation when you're focusing on one piece. So try to finish off one piece which has been cut and made free, and then go on to the other parts of the nucleus.
Maybe if I can add on, reduce the phaco power either directly on the console or using a foot pedal. That also reduces the chatter to some extent.
Yeah, power
Yeah.
reduce.
Yeah, Dr. Sanjay Mehta, any comments from your side? You're muted, Dr. Mehta.
Yeah.
We can hear
Yeah, Rajiv, it is so nice to catch up the galaxy of ophthalmologists, and I'm based at Chhattisgarh, and it's a delight to watch. And what a lovely phaco surgery you've shown. I'm just happy to watch. Thank you so much for inviting.
Thank you. Any other comments from the panelists?
I would just want to ask a thing. How do you take care to prevent the incision burn? Because at times, because of these hard cataracts, you tend to realize that you've had a burn. So what exactly should be taken care of?
Dr. Minu.
Yeah. If I have to say, see, remember there are 3-4 things which will make your wound burn. See, first thing is to do phaco with the tip clogged, and you don't realize that, and there is no flow, and you get a burn. Second thing is that you press on the side of the incision with your needle or your phaco probe, and you don't look at the, see, when you're looking at the nucleus, you don't look at the incision. You can't look at the incision. So that is the problem, when you don't realize that you're pressing with the needle onto the edges or top or bottom, when you're tilting too much or pressing on the incision. So that also we need to avoid. The third thing is to try to reduce when you're using longitudinal. The torsional, it doesn't happen that very often. But in longitudinal, if we think that keeping too much of power will help you, it may not. So you keep adequate power with your machine, whichever machine you are using, and try to use the aspiration flow and the vacuum to your assistance, and get occlusion well, and do phaco while you're occluded well, and use the vacuum much, and reduce your power and cut it down into micro bursts or micro pulses, so that you get a lot of cooling time in between. And also some people use fluid flowing on top of the incision by the nurse, and also the sleeve. Some people use high infusion sleeves, which can let in more fluid and more cooling. And these are the things which, and OVD burn, that is very important. We think sometimes that viscoat, which is very useful, we fill up the whole chamber with viscoat, and these things can clog the tip initially when you start off phaco, and then in a moment you can get a burn. So when you're putting viscoat, we need to make sure that the viscoat goes up onto the endothelium. So what I do is I put viscoat on the upper part of the anterior chamber, and into the phaco, say a phaco zone, or into the bag or in the pupillary area, I put HPMC, because we don't want the viscoat to be there in the rexus area, which will anyway get aspirated, and that will also cause a phaco burn. So these are the things which I would suggest to reduce.
Thank you, Dr. Minu. On a lighter side, maybe some chilled BSS might help. Professor Titial, can you give us a few tips on how to avoid this?
Well, I think most of the point Dr. Minu has highlighted beautifully. And whatever said and done, sometimes we do use much more amount of phaco in these cases compared to other grade 3 or grade 4 nuclei. The only thing is giving a little bit of cooling time surgically, or a machine will give you that profile. And use of soft shell technique is really handy in these cases. But given importance to endothelial function, if you have a good endothelium, next day patient has a clear cornea. Sometimes even a soft shell technique doesn't safeguard the endothelium in these cases. So I normally would like to do a specular count in these patients if possible, because these are very difficult cases, and sometimes patient will be on your head next day, like I can't see well, and the edema will take some more time to this thing. And we know that sometimes near the wound area you do have a edema, because Descemet might get disrupted. Apart from the wound burn, decimal detachment is quite common in the hard cataracts. And that has to be safeguarded. And sometimes you might have to put suture because the wound may not close appropriately as you think. The suture may be required in a very, very hard cataract where the wound had totally got distorted. Otherwise, the new machines nowadays, we can manage these cases very effectively without causing a wound burn, because that's I consider issue of past nowadays with the new system we have. Hardly get a wound burn nowadays. People know how to handle these cases.
Some of these incisions also, and the sleeves which we get, some of them don't match actually.
Yeah.
So 2.2 they say, but it will be 2.4, and it will get squeezed inside that. And so always I have a 0.1 in the inner aspect more than what is required, and even a 0.1 more than what they suggest will be better, rather than having a very squeezed kind of wound. But then if you go a little large, you'll have leaking. So that we have to make sure.
Dr. Ramesh from Lucknow, I think you handle a lot of hard cataracts in your practice. So
Definitely. My one question is, how frequently you face the problem of clogging of tubing especially in grade 4-5 hard cataracts?
We used to have it in older machines, but then nowadays I don't see much. But then previously we used to have definitely the compact machine and the moderate end machines. Some of them, they get clogged in the tubing. So that we'll have to prime them again, and then only.
You do have sometimes, as you do face this, but you can always know that your handpiece is going to get clogged. And you know that if you have that situation before it gets clogged, sometimes I shift to IA mode in a high vacuum. That will take away the little bit of pieces which are there, and you can still go with the phaco without coming out and reprime the handpiece in these cases. What earlier I used to do before I shifted to this we can say new tips. So I used to use a mini flat tip earlier 0.9 and use the thicker sleeve of a routine standard sleeve. So that will give you more fluid without compression, and you can still do a good phaco without wound burn. So those tricks can be used also.
So I think let's move on from the south pole to the north pole, that is from the hard cataracts to the ultra soft cataracts, and this time we'll have
Rajiv, just actually Harshul has requested he has to leave, so
sure.
Can we just allow him to
Sure.
So he'll be presenting on managing small pupil.
Thank you so much, Rajesh sir, Dr. Rajiv and Tityal sir, for giving this wonderful opportunity. So I'll be speaking on management of surgical management of small pupil. We all know that the small pupil can create a lot of problems for any phacosurgeon. So we need to tackle these kind of cases. We need to have some devices with us for management of small pupil. So this is the first device which I'm going to show. This is the Mulligan ring. We all know that the classical Mulligan ring was made of 4-0 polypropylene. It has 4 scrolls, and the newer version Mulligan ring 2.0 is made of 5-0 polypropylene, and it is more flexible, and there is increased scroll width. So it becomes much more easier to engage the pupillary margin whenever we are engaging. So this is the Mulligan ring. It comes in this housing, comes with this injector. So we need to pull this ring in this tube here, and both lateral scrolls and all the scrolls go in this tube. So remember, we need to put some OVD beneath the pupillary margin before we start injecting the Mulligan ring. So newer version 2.2, it goes through 2 mm incision. We need to put Cuglin's hook through the side port, which helps in manipulating the ring, especially the lateral scrolls and the proximal scroll. So the leading scroll, it goes out and engages the pupillary margin. We can most of the time engage the lateral scroll simultaneously and just tilt the tube to one side and release the proximal scroll from the hook. So once you take out this scroll, you may go through side port or the main port to engage this proximal scroll. So once this ring is in place, we can see that the pupil, it is maintained, it's become circular in shape, and it remains dilated to 6.25 millimeter in size. This is another way by which we can reuse this Milligan ring. So this is the injector of these micro lenses which goes through 2 mm incision. So in the same way we load the lens, the ring is loaded, and again leading scroll comes out, and see how beautifully the lateral scrolls come out. This is the case which had undergone penetrating keratoplasty and had some posterior synechnias here. So many times you need to use bimanual technique to engage the proximal scroll if pupil is very small. So you need to stretch the iris from one hook and engage the proximal scroll. So the beauty of this ring is that it lies in the pupillary plane. There is no tenting of the iris tissue, like in the cases of the iris hooks, which tents up the iris. And once this device is in place, we can exactly gauge the capsular axis size. Here, I'm enlarging the capsular axis size. You can move the ring to one side or other and make a perfect centration of the capsular axis, which is very important for good effective lens position for these premium irons. So to take out this ring, you need to disengage all the scrolls nicely, and either you can use the same Q-glance hook, invert it, and take out this ring, and it finishes the case. Or there is another way, you can just disengage all the 4 scrolls. Be careful while disengaging the scrolls that you don't damage the iris tissue. And you can use the same injector also to take out this Milligan ring. So go ahead, put some OVD above and beneath this scroll, and go with this injector, engage the proximal scrolls, and use the Q-glance hook or any Lester hook to guide these scrolls. See, so I'm just using this Q-glance hook to guide these lateral scrolls to go in this tube, and you can take out this ring to the same injector. So with another case of angle closure glaucoma, again I'm using the cartridge to push the ring. Many times you are able to engage just 2 scrolls. So you can just rotate the scroll, get this scroll in front of you, and keep on engaging the scrolls here. So there's a 3rd scroll which is engaged. Again, I rotate and go through side port and engage all the scrolls of the ring. This is the case of IFIS. So it has become a protocol now to use Milligan ring in these cases right at the beginning. So here the Milligan ring goes, and these are the hard cataract also. So once you take off the cataract, take out this ring, and you see the iris starts coming, it comes down and also start coming toward the incision. So this is how use the Milligan ring. So a word about the iris hooks before I finish my talk. So this is the unedited video. So if you have to use iris hooks, remember that the positioning of the iris hooks has to be perfect so that we get the maximum view. So important thing is that 2 hooks have to be there near main incision so that there is no iris tissue ledge which comes in between when you are doing phaco. So maybe you need to use 5 iris hooks to create a good opening here. So this is how we should place iris hooks, and iris hooks has to go from posterior limbus so that tenting of the iris tissue is less. And once they are placed, you can easily complete the phaco and finish the case. So but the disadvantage is that, of course, we need to make extra ports for these 4 or 5 hooks. But you can safely use them. Put the IOL and one by one take off all the iris hooks, and this finishes the case. So with this, I come to end of my presentation. Thank you very much.
Thank you, Dr. Harshul. Those 5 hooks are very fond of, because the 2 hooks that we put close to the main wound pulls the iris tissue so well into the periphery that the thing, and then there is no iris chafing by movement of the probe. And of course, the rings that you have shown is fantastic.
Only one thing that I would like to kind of comment, rather than using 5, it's an excellent idea.
I think some noise is coming, which is
Dr. Sanjay Mehta, I think Dr. Sanjay Mehta.
Admin can mute them.
Yeah, thank you.
Dr. Rajesh.
One option that I do at once in a while when I have this kind of an issue, if I'm using 4 hooks, I would place one of these hooks sub-incisionally.
Yes.
So that also does the trick. I think we have Dr. Dipti Govila who's would like to comment on this. She's a prolific cataract surgeon in Delhi and wonderful surgeon, I must say.
No, so this 5th hook definitely would help in getting access and prevent the iris from doing the tenting and then creating less space in chamber. This 5th hook, if you can place it right sub-incisionally, it is of great help. But sir, I would like to just ask something regarding the sphincterotomy. Do you still, in some cases, do you still consider going in for sphincterotomy to take care of the small pupil scenario?
No, usually I don't use sphincterotomy. See, with the beautiful devices which we have, which are so atraumatic to the iris tissue and which doesn't damage the sphincter much, So my choice is first Milligan ring, and if any chance I have to use, maybe iris hooks. That's it. So game plan is very simple.
Yeah, even in pseudo exfoliation cases, it works well.
Yeah. Of course, works for all the cases.
Actually, while putting the hooks and rings, our idea is not to damage the sphincter, so that we don't have a sphincterotomy at all. So that is, that's why we want to have a mostly minimally traumatic of these rings and hooks, so that you don't damage the sphincter. Because
Moreover,
that's permanent to the pupil.
Just a small comment on this small pupil thing. At times, we just barge in using all these devices, and we just forget to just begin with just putting some pharmacological agent first and see the pupil's behavior before we sort of.
True.
Yes. So that is our first line of attack. Whenever we go out for surgery, pupil is small, put Phenocan plus, and usually these kind of people, they don't dilate. So if they don't dilate, of course, you have to use any expander device of your choice. Whatever you use, BX ring, Milligan ring, OSS, hooks, whatever. But the another beauty is that you can use Milligan ring and these devices, BX ring, under topical also. So for maybe iris hooks also, we can do under topical, but still you need to make 4-5 incisions for that.
So, thank you, Dr. Harshul, and it was
thank you so much, sir.
Wonderful, set of cases. Now we move on to another young and very dynamic surgeon, very good surgeon, Dr. Shal Vasavada, who will be talking on soft cataracts.
Thank you very much, Rajesh sir, for this wonderful opportunity. And after seeing all of these very difficult cases, my presentation is a little bit of a mismatch for this wonderful meeting. To start, we do receive research grant support from Alcon Laboratories, and these are the cases that we are typically talking about, where there is hardly any form of nuclear sclerosis, but there is a lot of either posterior subcapsular component or some cortical component, which is actually bothering the patient's vision more. And therefore, these patients also tend to present early on. And generally, they are also likely to be younger patients compared to our senile cataract patients. And unfortunately, soft cataracts sometimes don't behave predictably the way we have been used to seeing these wonderful chopping videos and so many different ways of managing the nucleus. So therefore, we need a surgical strategy which is safe, effective, and more than effective, predictable, which can be replicated in most of the soft cataract situations. So this is a typical case of a soft cataract. You need a decent size rhexis. So if you have a very small rhexis, sometimes if you end up in a slightly of a bowl kind of configuration at the end of nucleus division, it will be very difficult to prolapse that bowl out of the very small rhexis. So you need a decent size rhexis and a good hydro dissection. Hydrodelineation is also a good option to consider. My first preference would be to just go ahead and see how things go just with hydrodissection. Second thing is that we need to keep in mind that all of these stages, whether it's the soft cataract or hard cataract, we need to have different parameters for different stages of these cataract surgery. And the most challenging part of cataract surgery in a very soft cataract is the nuclear division. Chopping doesn't always work. So even if you use zero power and you try to hold on with vacuum, sometimes it just cheese wires. Like in this case where it doesn't appear to be that soft a cataract, it appears to be a decent density cataract. And therefore I decided to go with a regular strategy of first creating a trench, and once the trench is created, go for chopping. So I'm using very little power, 20 Auxil only, so that I don't end up eating too much or I don't end up going through and through. And typically I would like to create a longer trench to try and divide this maybe into 4 quadrants to see how this goes. Now, this is what typically sometimes happens. You end up first trying to chop. Here I'm trying to chop. I just don't get enough grip. Then I try to again go back and sculpt and thin the center, that maybe now I'll get some grip on the nucleus somewhere to try and divide or try and rotate. And then the eye environment keeps changing. The iris tends to prolapse. The fluid keeps going below the iris. Pupil becomes small, so on and so forth. And then you end up in a situation where you are neither here nor there. So you are neither left with a situation where you can chop, nor now you are even left with a situation where you can even attempt 4 quadrant. And this ending up of this bowl kind of configuration is the most difficult or challenging, and particularly when it's not extremely soft, not jelly soft like a 30, 35, 40-year-old patient with cataract. If it's a 50, 60-year-old, this epinucleus itself is also quite tough. And the same patient now, having been frustrated, not able to divide this way or that way, I thought maybe this center area is thin enough. Let me go ahead and remove this nucleus and try and bring it to the center. But until it is not very thin in the center or it's not divided at the center, it will not allow this nucleus to prolapse out. So this is what typically tends to occur in a soft cataract. We tend to get frustrated and we keep moving from one strategy to the other. So my preference or our preference as in general is to not just even think of attempting a chop when I know that the cataract is grade 2 or less. So when I'm planning to do a cataract which is grade 2 or less, it's already in my mind that I'm going to attempt a 4 quadrant technique at first rather than doing or attempting a chop. And for 4 quadrant, you need not only a deep trench, but you also need a fairly long trench. And for that, we tend to use appropriate parameters. So you use a very low flow rate and a low power. So because these cataracts are not very dense, you don't need very high power. And as you keep going down, make sure that when you come to the edge or to this side, you lift up your probe, because this is the cataract is like a bowl. So if you keep going at the same depth, you may end up going through and through the posterior capsule. So make a deep trench about 3/4 of the depth of the nucleus. Use a low flow rate of 14 to 16 cc per minute, so that even if it becomes very thin, you don't inadvertently go and catch the posterior capsule. Use a low ultrasound power and a low bottle height or low IOP, whatever machine that you're using. So this is a typical case of a grade 1 to grade 2, where I've decided that this is the patient where I'm not even going to think about attempting a chop. So after the first few sculpt, I realized that this nucleus is not going to be dense enough to give me enough purchase to chop. So we go ahead to change to plan B, that is to consider a 4 quadrant technique. Create a trench on the first side, create a longish trench, go below the rhexis, and then keep making it deeper more in the center, because it is the central plate which will actually hold the nucleus or which will not allow it to divide. Rotate the nucleus on the other side, complete it 180 degrees before attempting the third and the fourth sculpting. And once this 180 degrees is done, you keep rotating 90 degrees and create this cross, making sure that there are no ridges left in this. So this ridge that you see here, that we need to thin out so that there are no ridges left in the cross. And now this nucleus will be easy to divide into these 4 quadrants. So coming to fragment removal, once you have thinned them enough, you want to make sure that you separate them not just at the edge, but make sure that they are separated right up to the center, because you want them completely free from the center, because the center which will allow, if the center is divided, it will allow the nucleus to prolapse when you try to remove the fragment. So make sure that you completely separate all of these 4 fragments that you have created. And now, while going for lens removal, you may struggle because there is very little space in the middle. You may struggle to remove the first fragment. And most of these fragments, because there are only 4, will be large. But because they are relatively soft, it's not too much of a problem or too much of a threat to the endothelium. And once one fragment is removed, then rest of the part is easy. But still, you want to try and maintain the principles that you don't want all of the fragments prolapsing out into the AC, like making sure that this last fragment, until we remove them, remains in the capsular bag, so that there is less turbulence and therefore less damage to the iris as well as the endothelium. And use your left hand to reposition the fragments. Make sure that your right hand remains very stable and centered in the center of the capsular bag, so that the fluidics are well maintained. So again, low ultrasound, because this is not a dense cataract. Flow rate is something of anyone's preference or choice. Typically, we do not use a flow rate more than 25 cc per minute, but anywhere 20, 25, 30 cc per minute is a good flow rate, and you don't need a very high vacuum to remove this nucleus. This is a case of flax, but to highlight that you can actually use the cylindrical lens division patterns, which means hydrodelineation. This was a very young patient and a very soft cataract. So, I mean, even attempting a 4 quadrant would have been difficult. And therefore, these sort of rings act as multiple hydrodelineation. So we remove one from the support of the other. And once the central entire nucleus core is removed, I'm trying to bring out this entire thick epinucleus plate, rotating it and making sure that it sort of prolapses by rotating all through around all 360 degrees. And therefore helping in removal. So in an extremely soft cataract where you find that even sculpting will cheese wire, maybe multiple hydrodelineations may help. This was a case of femtosecond based that kind of pattern. So I think for the pearls for soft cataract emulsification is you need to modify your approach and get out of the mindset that chopping is the only way a cataract can be divided or separated. We find the 4 quadrant nucleotomy technique or 4 quadrant technique very, very efficient across most grades of soft cataract or even moderately dense cataract, which are neither here nor there. Then this typically occurs in young myopes, where they have a very small central nucleus, and by the time you do the first trench or the first chop, that nucleus is gone. And then you are left behind with a very thick epinuclear plate. So a 4 quadrant technique is not something which is a shame to go back to, and use low aspiration flow rate so that even if you end up being very thin, while sculpting, you don't end up catching the posterior capsule. Hydrodelineation, again, is a good trick in extremely soft, very jelly cataracts in their very young ages. So thank you so much once again for this opportunity. And I'm sure there are more than several other ways of belling the cat.
Thank you so much, Dr. Vasavada. Indeed, you downplayed your topic so well, and it is actually very, very difficult to handle extremely soft cataracts at times, perhaps more difficult than hard cataracts. I'm sure everybody on this panel will agree. And your presentation really made a difference to the learning towards the approach in handling these cases. Dr. Arun, I would
yes,
your comments and any questions that you would have.
Yes, most of the points already highlighted by Dr. Shell. Even though it's a soft cataract, but still you have to take the care because it may turn into the complications. As already he had shown that 4-quadrant is not the good way. Hydrodelineation with the help of the hydrodissection, which is called as a rapid, in which case you may just prolapse the nucleus into the antechamber and aspirate it with the help of the vacuum. It is also one of the best technique to do the phaco in the soft cataract. Otherwise, all the points already highlighted by the Vasoda sir.
One of the techniques propagated
is a rapid.
By a prominent surgeon in US is tilt and flip technique in very soft cataracts. But I
lens salute.
don't have any experience on this. I will request Professor Titial to throw some light on this. You're muted.
Yeah. Maybe I think Sal explained beautifully the entire range of soft cataracts and managing them. And I think the basic concept is to have a good hydro procedure in these cases.
Yes.
That makes the life very, very simple in these cases. Then you can use any technique. And most of the time, if you have very soft ones, actually need to have some sort of separation to flip or chop it or similar. So I normally go with the Giro. I call it a vacuum hold and separation.
Yes.
And that works out very nicely. If you have a good delineation, very rare chance to get into posterior capsule in these cases. Many people use viscoelastic to lift the entire epinuclear cushion. That is also very helpful in these cases because taking out epinucleus becomes very tough. Once you do a multiple delineation, so you have a sheets of epinucleus, and that will take patience sometime, and you might end up doing something mischievous. But slow aspiration and little bit of a phaco whenever you have a thing which is right in the center and which is delineated, that works out very beautifully in these cases. But as Rajiv commented in the beginning, soft cataracts are more difficult than a hard cataract sometimes.
Yes.
Thank you so much, sir. I think we'll move on to the next subject on the topic. I think we have Dr. Purnendra Bhasin with us. He's actively involved in the Trauma Society, and hence he was called in to do a talk on traumatic cataracts. And he's an amazing surgeon, by the way. Dr. Bhasin, over to you. You're muted. Yeah. So,
can you hear me and can you see the screen?
Yeah, just put it on slideshow.
Yeah, that I will do. I'm doing.
Thank you so much.
Thank you. At the outset, I would like to thank Dr. Rajesh, Professor Titial, and you personally for giving me this opportunity to be in this for showing my cases of traumatic cataract. I have no financial disclosure. Various causes are there. There could be closed globe injury or open globe injury, which can lead to traumatic cataract. So my first case is a case of blast injury. This patient came to us who had a cracker blast in a marriage. This was, I think, 4 months back or so. So he's a 17 years old male with a bilateral multiple pallets over the face and in the anterior segment, and in the posterior segment too. The vision, both eyes was PLPR. IOP was in right eye 18, left eye 40. Multiple embedded corneal and scleral foreign bodies, post-perforating injury, and mature perforated lens capsule traumatic cataract. And in B scan also, we could see multiple small pallets in both eyes. So this is what we, on that first day, we planned to do the cataract surgery. And this is the right eye. And you can see there is a posterior capsular opening and a foreign body inside. So with the vitreous cutter, I am aspirating the cortex. I've made it a bit fast. And you can see this is the foreign body there, which is floating. And I was trying to bring it out through anterior approach only. There is a primary posterior capsular end. And with the help of vitreous cutter, I have removed the cortex as well as the vitreous. We left the case as such. And after 5 days, we took the other eye after controlling the intraocular pressure. And in this eye, what we missed in the previous eye, we used the infusion cannula in the posterior segment. And there was a wound of entry here. We sutured them, and then there is a ruptured anterior capsule. Multiple small wounds were sealed. Going ahead. And a similar technique was adopted. With the help of vitreous cutter, I am removing this. So this is what I do in these cases when there is a primary posterior capsular rent. And this foreign body was floating because of the presence of infusion cannula. This didn't go back in the vitreous cavity. And then we pulled it out through the paracentesis because there is a fluid pressure inside. So we sutured this. Iris was tending to come out repeatedly. We finished the case, and we didn't do planned IOL in both eyes initially at the first sitting. We have done a secondary IOL later on. This eye, we have removed all the cortex, and then the wound was further sutured. Infusion cannula is removed. And after 10 days, right eye pars plana vitrectomy was done to remove the foreign bodies. Then we took for the same eye for the secondary IOL implantation. And as you can see in this particular case, we are releasing all the synechnias. Pupil is small. I'm checking the presence of the sulcus. Our capsular axis is intact, and a 3-piece IOL is then placed in the sulcus, implanted, and optic capture is done. After 7 months, in the other eye where there was no capsule, we did a secondary IOL by fixating the haptics to the sclera, and in this way by modified Yamanis technique, because there was no posterior capsular support in this particular case. So all these cases can be managed independently. There are various ways of rehabilitating these patients. Maybe you can use retroiris fixation. This flange is created, and this was done 7 months after the previous surgery, so that retina and everything is fine, and this haptic is pulled out, and flange is created on the other side. So this is how the case was managed. So the corneal scars with stable IOL and retina was there postoperatively till date. And the best corrected visual acuity in right eye is 612, where we did a Yamanis technique secondary IOL, and in the other eye, it was 6/9. So cornea is clear, and the patient is happy with the vision because he came totally blind in this eye, bilateral blindness. Another case, this case we were doing a regular surgery, routine surgery. There was a synechia, and patient gave us the history of trauma, but there is no wound of entry, visible wound of entry here. Capsular access is done, and after removal of the cortex, you see there is a thick fibrous plaque posteriorly which is visible. I'm trying to remove it, but suddenly I find something is there inside, and this brownish thing is a foreign body which is embedded in the lens. I filled the chamber with viscoelastic with the help of a microforceps. I'm pulling it out, and I brought it. This is a thorn which has gone inside from anywhere. I could not see the wound of entry. And then this plaque we cannot remove because this was thick, dense, and we tried to do some, try to polish it or try to remove it, but it was not. It was a fibrosed kind of thing, granuloma kind of thing, which is there in the posterior capsule. And there is no vitreous damage, vitreous loss, or extension of the posterior capsular tear. So another case wherein you can see is a post-traumatic sealed the corneal tear, and there's a cilia in the anterior chamber. This is the eyelash. So before going further, and there is a small pupil. So eyelash is removed, and then we go further and do the cataract surgery. In this particular case, all these things, sometimes we get foreign bodies or cilias, and this is how the posterior capsule is there and the lens is placed inside. This is another case, young boy, I think 6 years. His friend has pushed past a pencil, and the tip of the pencil lead has gone inside. This is the wound which we have sutured before taking it further. And at the same sitting, we have removed the foreign body. Synechias are released. This is the wound of entry. There is a rent in the posterior capsule. Because this posterior capsule was opaque and the child was young, so in this particular case, we did a primary posterior capsulotomy. Our anterior capsule support was there. I am releasing this synechia, which is adhered to the cornea. Anterior vitrectomy is being done, and remnant of cortex and a single piece PMM lens is placed inside, because I was not sure of the extension of the anterior capsular tear could be there with the foldable lens. This is another interesting case. There are multiple tiny foreign bodies which are present. You can see on a B scan present in this particular case. Patient has developed a rosette cataract. There is a synechia here. We have released it, and primary capsular access is done. Bimanual lens aspiration, and then primary posterior capsulotomy we are doing, capsular access in the posterior capsule, because these tiny foreign bodies were lying anterior to the ciliary body region, just behind the iris. So we are pushing or indenting the adjacent sclera to locate the foreign body. With the help of vitreous cutter, we are cutting the vitreous present over there. To get a better visualization, we placed a capsule hook or iris hook, and this is the foreign body lying over there. And this is some kind of a metallic foreign body. Mind it, we should remove all the vitreous which is adhered to it, and don't try to pull it like this. We should cut it before and then cut it and then remove. So vitreous is a tissue or a body, we should respect it. Another case, young boy of I think 8-9 years. We avoid hydrodissection in cases where there is a primary capsular tear and there is a chance of having a primary posterior capsular tear. So anterior capsule margins are fibrous, they are cut, and then the cut margins are rotated in the form of a capsular access, and then a primary posterior capsulotomy. Because the child is young, there is a high chance of developing the posterior capsular opacification very early, and then the optic capture is done through this. This is what we do in all our pediatric cases to avoid, because in India the follow-up of these patients are very poor. This patient had a 6/6 vision even at 1 year, and there is the ovalization of the posterior capsule and the optic capture is done. Another case, young boy, post-traumatic sealed corneal tear. You see such a thick fibrous lesions are there between the anterior capsule of the lens, the iris, and the cornea. Then we remove this whole thing, which is present, a fibrous granuloma kind of a thing, with the bimanual technique, removing this whole thing and then enlarging and doing the pupilloplasty, so that our lid is not encountering, or the lid is not covering the pupillary area, this iris. And then a primary posterior capsulotomy is done. In these cases, we should, in the presence of the corneal scar, we should not leave the edge of the capsule in between, and when the area of we are passing through the area of corneal opacity. And in one go, we should do this. I have done a iris opening in this primary PI, so to avoid any chances of secondary glaucoma in these cases. This is the last case. There is a large, you can see a corneal limbus parallel tear which has been repaired 3 months back, and this was, a patient was having vitreous hemorrhage. So because of the presence of heme or vitreous hemorrhage, there is a reaction, and this is not the capsule or the lens capsule. This is the anterior vitreous face is opaque now. So in this particular case, we are planning a scleral fixated lens, the classical scleral fixated lens, because there is no support to the lens. Otherwise the lens can go behind. This is the anterior capsule, not the anterior capsule, the anterior vitreous face, which is opaque. So with the help of vitreous cutter, we have created this opening in this anterior face, and there is no iris also in this particular case, you can see. So this will act and reduce the glare in this particular case. So the two cut ends are tied to the eyelet of the haptic of this scleral fixated lens. Prolene suture, or maybe you can use a Gore-Tex suture, that is our choice. And mind it, all these sutures should be embedded in the sclera. Otherwise, they can irritate and that they can cause they can be a nidus for the endophthalmitis or infection inside. So this should be covered. The haptics are now, this prolene suture is tied to, embedded and tied to the sclera. This is done on the other side. And all these wounds should also be covered with the conjunctiva to avoid any infection. This is how the patient is at the end of the surgery, well-centered IOL, no damage to the, no further damage to the cornea, and no damage to the vitreous. So there should not be any vitreous present in all these cases, and we should respect the vitreous in all these trauma cases and respect the available capsule which is there, because that can be support to the present the place for the placement of the lens. Thank you.
Thank you, Dr. Bhasin, for some really mind-boggling cases that you have shown. That was really wonderful. From any other
Trauma is something where you have to adapt to the situation at each stage. Every case is challenging.
And you have to innovate based on, depending upon what is the scenario.
No, that was indeed excellent by Dr. Bhasin. And one question I have, I mean, in all these cases, do you use an intracameral antibiotic at the end of the case, or just treat it as a routine phaco investigation?
I use intracameral in the anterior chamber Vigamox in all these cases. That is my standard protocol. In all these cases, we use it.
Dr. Kataria is here, prolific cataract surgeon. Any comments?
Yeah, it was an excellent case, Dr. Bhasin. Congratulations. I think so. This situation can be managed when you're in a multi-special, very big center where you have all vitrectomy and everything possibly present there, so that you can manage it appropriately. And you've done an excellent job, I must say. That was great. Thank you.
Thank you, Dr. Kataria. You are absolutely right. I think we should have a VR backup. Retina surgeon should be always be with us in all these cases, because all these cases are challenging, and we need to have a cornea person and a retina person as and when required.
Yes.
Thank you. So we move on to the last talk, and that is by Dr. Rajesh Joshi, who will be showing us the tricks to manage a fibrotic capsule and perform a good cataract surgery.
Yeah, at the outset, I thank Ascaris for giving me this opportunity. I will be talking on cataract with the calcified and fibrotic anterior capsule. There are various ways to manage these cases, and those who are managing them routinely, they can manage the way they want. But how do I manage these cases? Let's see, and there are a few tips which are attached to each and every videos. So though the situation is rare, we commonly see in rural population in patients who present to us with long-standing cataract. They are associated with zonal weakness and hard nucleus. Now, what are the difficulties they come across? The capsular axis is difficult because if the capsule is fibrosed, it may not behave the way you want while performing the axis. It may go haywire. The capsule is white, so the staining is most important. And those who are used to performing or creating capsular flap with the help of with the help of capsular axis forceps, they may not be able to create the initial cut with the help of utrata forceps. They may have to use bent 26 gauge needle, and they should have a good vanas and micro scissors. And nucleus management, of course, that is most important part of the whole procedure. And you can expect surprises because sometimes there are zonal adhesions which may occur at any stage, or there may be the catch of the rhexis margin. So I will present this first case, 70-year-old male having accurate PL and TR, Adara having mature cataract, rest ocular examination was normal. So you can see this calcified anterior capsular plaque along with the fibrous bands on the anterior capsule. So we started with the side port incision and the staining, which is most important part because the capsule is white, and if you have a long surgical time, the capsule, you may not be able to see the capsule later on. So the staining is the most important. Clear corneal tunnel and creation of the capsular axis with the help of utrata forceps. I usually do with the utrata forceps, but it wasn't possible in this case. So I created with the help of 26 gauge bent needle, and it was difficult. It was difficult to rotate the capsule. So I introduced micro forceps and micro scissor through the side port, and I'm cutting the entire capsule with the help of this scissor. So soaked up capsule is there. Now, while performing all these maneuvers, you expect that the zonals may not be strong. Of course, enlarging the rhexis part is important, but you can do it at the end. So I'm putting the endocapsular ring to stabilize the zonals. Now the cataract is not that hard, it's a brittle one. So you can chop the nucleus the way you want, but I usually use the chop technique. The video is fast forward mode. So chopping the nucleus, and the nucleus is out. So there is almost no cortex inside. So placing intraocular lens inside the capsular bag, the bag being small, sometimes you may face difficulty in pushing the lens inside. Now enlarging the capsular axis margin. With the help of forceps and the scissor, you can enlarge the capsular axis. Now washing the remnant viscoelastic and the cortex. Sometimes this cortex gets stuck to the capsular axis margin. You may not realize till at the end you are clearing the viscoelastic from the anterior chamber. Now sealing the incision is very important because if you are using a lot of power, there may be leakage of the wound. So you have to do proper sealing of the wound, and sometimes I put the trypan blue over the wound so that you can see if there are any leakages, you can always suture the wound. These are post-operative follow-up of the same case. Now tips as far as this video is concerned: need good micro scissors and forceps for CCC. And if you have encountered any zonal adhesions at the end or in the beginning, you always implant the capsular tension ring, and the chop technique, which puts less stress on the zonals, is important. Zepto and Femto, I don't have any experience, but I think they should come handy in this situation. Panelists, they can highlight on these procedures. Now case 2, 65-year-old female presented with pain, redness, watering left eye otherwise pseudophakic. IOP on presentation was high. Diagnosed having phacolytic glaucoma. After control of pressure, patient was taken for surgery. Now you can see the brown nucleus which is settled in the capsular bag along with calcified capsule and some fibrosis also. The capsule is stained with the help of Trifam blue, and I am doing the capsular axis with the help of needle and the forceps. The axis may not be difficult in this situation, but managing the nucleus is the most important part, because the nucleus is mobile in these cases and it moves. So chopping becomes difficult. So you should have optimum vacuum to hold the nucleus, and you can chop later on. Once you have two pieces, you can chop, make into multiple pieces, and then aspirate the nucleus. You can see at the initial chop, my phaco probe was in the bevel down mode. Now most of the phaco tips, they are available either in the 15 degree or 45 degrees. So now we don't have that 0 degree tip, which we are missing in these cases. So bevel down tip is good for hold of nucleus in such cases. Vacuum should be optimum, remain in the center part. Do not move probe towards the nuclear fragments, because you may catch the posterior capsule or the capsular axis ring, and there should not be any surge during the procedure, because there is no cushion of the epinucleus. So there are, even if a small surge, you tend to catch the posterior capsule. Now, third case, 80-year-old female presented with hypermature cataract with calcified fibrotic anterior capsule, otherwise pseudophakic. You can see similar type of case, but having fibrotic capsule and a lot of calcification. So we started with clear corneal tunnel and staining of the anterior capsule. If you have such type of folds on the anterior capsule, mind you, they will give you trouble while performing the capsular axis, because at these ends, your axis is going to go towards periphery. So I decided to go with initial clear corneal incision and performing phacoemulsification only. So created clear corneal incision and trying to do capsular axis with the help of needle, finding out the clear area which is non-fibrotic on the peripheral part. But that part of the axis was going towards the periphery, and it was difficult to bring the axis in such cases toward the center part because of too much of fibrosis which is there on the anterior capsule. Certainly, I did capsular axis, but it was huge. It was extending towards the periphery, and the nucleus was also very hard. So I was skeptical in going ahead with phacoemulsification. So I thought better procedure would be performing small incision cataract surgery. So I shifted towards the superior side and created a tunnel superiorly, which was on the larger side, extended on the either side of the tunnel. It was really a big tunnel. The nucleus was brought into the anterior chamber. It was big nucleus with calcification all over, and with the help of viscoelastic, the nucleus was removed and we implanted 3-piece IOL in the bag. So this is how I saved my day, and the tunnel was hydrated, the side port was hydrated, and this was the post-op follow-up. So SICS comes handy in such situation. So these are my few cases, and thanks for.
Thank you so much, Dr. Joshi. That was indeed fantastic. The idea of handling these capsules, be it calcified or fibrosis, to work around the lesion, go outside the lesion, and then try to, fashion your capsular axis accordingly. And perhaps at times your curved vanas or your curved microscissors might be your best friend. I would request Dr. Charu Goyal from Sitapur to kind of comment, or does she have any inputs on this?
Yes, I think these cases with the calcified capsules, they have 3 hurdles. First is the capsule, which you have to handle. And almost always it'll have a hard cataract beneath it. So you have to handle that. And then third, it may or may not have weak zonules. So it is a very difficult case. And it has been handled very well by Dr. Joshi, because I know he's a very fast surgeon. So I think you must have lowered the parameters for these cases, Dr. Joshi, because these cases are extremely difficult. And the fibrotic capsules, the only thing is that the only good thing about the fibrotic capsule is that it gives you a lot of time, because other cases, the rhexis is always running towards the periphery. Here you have a lot of time. You can, but you need instruments and you need a lot of patience handling these cases. It has been done very nicely, Dr. Joshi. Thank you.
As far as the parameters are concerned, at the end of the procedure, you should lower the parameters. Otherwise, you can keep the parameters same throughout the procedure.
Yes.
Depending upon the choice of your surgical technique.
Okay.
Dr. Ramesh, I'm sure at your center and in your hands, you get a lot of cases like this. How do you handle them?
My question is, sir, how frequently you come across posterior capsular opacification along with this kind of subcapsular opacification and such kind of capsules? And if it is thick plaque on the posterior capsule, how do you manage that cases? Dr. Joshi.
Yeah, I think performing posterior capsular excision is always a good idea, because that is not that difficult. But if you have a small calcification or a small plaque at the mid peripheral part, which you can ignore, that can be done, because later on you can always do YAG if you have a facility which is available with you. Otherwise, performing posterior capsular excision is a good idea in such cases.
So I would like to give a take-home message on this. I mean, if you're not equipped to do a primary posterior capsular excision, it is not mandatory for the surgeon to do a posterior capsular excision. Don't worry about it. Just put your IOL there. You can always do a YAG, which is much safer later. But since
can I just add one point here? Can I just add one point here? In some of these cases, you do get to see plaques, and these are thick plaques. And they are attached to the capsule. The posterior capsular excision you have to do, or YAG capsular you have to do, if it's a fibrotic capsule itself or a opacified capsule. But sometimes you do get a plaque which is adherent to the capsule. With the help of any instrument, if you create a cleavage plane between the plaque and the posterior capsule, then in that case, you can lift the plaque and you can clear the visual axis completely. So, I mean, there are many cases wherein you do get such plaques wherein you can create a cleavage plane and lift it up and clear the visual axis.
That's a very good point, Rajesh. Since you're here, and I'm very glad you're here now, well, I'd like to ask a question to you. Is that if you have these cases with anterior capsular fibrosis or maybe anterior capsular calcification, like in hypermature cataracts, what is the efficacy of femtosecond laser? Or if anybody here has experience of precision pulse capsulotomy or the Zepto laser capsulotomy, I mean, vis-a-vis the femto, I mean, how do they perform?
Yes, when you're doing a femtocataract surgery, if it's a thick capsule or a fibrotic capsule, you have to increase the energy level. And if you increase the energy level, you can create a capsulotomy in many of these cases. But in some cases, even after increasing, if it's a very thick capsule, one of case that was being shown by Dr. Joshi, sometimes you do get a partial cut, even with the femtosecond laser, even after increasing the energy level. Then in that case, whatever you have separated, whatever area you have got a complete cut, you can separate, and then the remaining part you can cut it, or you can, if it's a part, some areas which are adherent, you can lift it up with the help of a forceps, or at times you may have to cut that part. But yes, femtosecond laser does help in thick capsules, in fibrotic capsules, in creating capsulotomy.
Anybody has experience on precision pulse capsulotomy like the Zepto over here? I don't foresee.
Actually,
I have done a
actually
few.
long back, we had just used for a demo purpose. It had come and we had used it, but I have never used it in a fibrotic capsule.
Dr. Minu had something to
I've
say.
also not used in a fibrotic capsule septo, and it came and went off just like that after a demo. But then femtos we are doing regularly, and the point is that you may get an outline. Most of these cases you'll get an outline, and the rest of the rexes it will be there, and you can follow that and then easily snip them off from the attachments. But sometimes mostly you don't get a full free floating or a full cut through these kind of fibrotic plaques, but then always you have a margin through along which you can proceed your rexus tear or even cut, as Dr. Rajesh is telling.
So basically what I understand,
many of these cases, what you get that partially you get a cut, so, and partially you get a sort of a margin or a groove or a mark. So you can sort of a circular capsule.
So after hearing the experts, what I understand or learned is that in these cases of fibrotic capsules or calcified capsules, you always have to have your friend next to you, which is your curved vanas or your curved micro scissors, which will always come in handy. Any comments from the panel or anybody wants to say something? Dr. Pawan wants to say something? Dr. Pawan, you're muted.
No.
Even if you have a cut which looks irregular, these kind of fibrotic ones don't extend to the periphery. So that is what you can be happy about and safe about. Even if it is not if you make multiple cuts like this, you won't get a continuous cut. You will get V-shaped extensions, but they don't extend to the periphery.
Yeah.
Hello, Rajiv. Why don't you just do SICS and get away with it? Go for all
we can. That's definitely a viable option. That's Pankaj, that's a viable option. But we're trying to salvage a phaco case. So in case somebody who's a phaco surgeon wants to do a phaco and has a capsule like that, you can always, we're looking for the suggestions how to improve and get away with it. But SICS is definitely a viable option where we can give snips on the capsular axis wherever required and take the nucleus out. So I agree with you. And any other questions from the attendees or the panelists or the speakers?
But even having a rexus and SICS is also good. So we can even cut and create a roundish kind of margin so that the IOL can be placed in a much better location.
Agreed.
Yeah. So, and Madam was in between asking about sphincterotomy in small people. I wanted to mention at that point of time, there are two types of pupils which will respond and not respond to cuts made at the margin. The lax ones, which are elastic ones, if you make a nick, it will remain like a nick, vertical nick. But there are fibrotic ones, which you make a nick, it will become like a V. So if you make multiple Vs, it will definitely increase in size by at least 1 to 2 millimeters. And that will be enough for most of the phacos. But then in elastic ones, if you make snips like this, it neither increases the size of the pupil and also it makes it more flabby and it comes into the phaco all the time. And in fibrotic capsules, even if you put hooks, you end up with the sphincter tears. For sure, if it is fibrotic, like in pseudo-exfoliation and fibrotic ones. So the point is, when you put iris hooks, you should not be extending it limbus to limbus. The idea is to get around 5.5 millimeter pupil and do your phaco within that area and do not pull it towards the more number of hooks again helps in reducing the tension between the hooks. So the tear will also be less ugly looking post-operative.
Yeah, the force is distributed amongst multiple hooks. That's what you meant.
Dr. Charu, any final comments since you are the panelist for this?
No comments as such. I think all the points have been covered and the case has been handled very nicely. And SICS is a very good option. That I also agree, because in these cases, since the nucleus, there are chances that the size of the nucleus will be very big behind the calcified capsule. So it's good to it's okay to do an SICS, convert into an SICS in these cases.
Thank you so much. If there are no further comments, I'll request our secretary, Professor Rajesh Sinha, to do the honors. Please.
Yeah. Thank you, Rajiv, for really moderating this session very well. And in the end, I would like to thank all the speakers. Wonderful videos that we could see by Dr. Rajendra Prasad, Dr. Minu Mathan, Dr. Shal Vastra, Dr. Purinder Basin, Dr. Rajesh Joshi, and Dr. Shultak. And we had a very good, very vibrant and very, discussing panelists, Dr. Aruna Chitre, Dr. Pawan Rao, Dr. Sanjay Mehta, Dr. Pankaj Kataria, Dr. Charu Goyal, and Dr. Deepthi Govila. And of course, I would like to thank all the speakers, all the panelists, and our staff, Mr. Anil Kumar, the IT person, Mr. Bageshwar, and our sponsor, supporter company, IPCA. And definitely, lastly but not the least, I would like to thank all the people, all the audience, all the ophthalmologists who have joined in to participate in this webinar. And thank you very much. A big thanks to you all, and hope to see you in some of the other webinars, some other activity that we will organize under the aegis of ISCRIS. I would like to tell you all that I invite you in the annual conference of ISCRIS on 6th and 7th of August, and it will be wonderful if you all join in. So thank you very much, and a very good night to all.
Thank you, Rajesh sir.
Thank you.
Thank you very much, Dr. Sinha. Thank you. Good night.
Thank you.
When
Good night,
is the
sir.
annual meeting in Delhi?
Good night.
Yeah.
Yes, sir. We are there only. Yes.
6th and 7th of August. Yeah.
Yes, sir. Good night, sir.
Okay. Good night. Thank you. Bye-bye.